Thank you, everyone, for joining us for this afternoon's panel session. We're going to get things started because our first presenter actually needs to get to the airport. That would be Professor Wasserman. So thank you. This afternoon's panel is regarding the use of data and analytics to optimize care. And what we're going to do today is we're going to let all the panelists present. Mort will escape, and then we'll take questions. And I will be handling Mort's questions to the best of my ability so he can make his flight on time back up to Vermont. Dr. Wasserman is a professor of pediatrics at the University of Vermont, and he is the director of the Pediatric Research and Office Settings Network, which is the Academy of Pediatrics Practice-Based Research Network. I believe he has been the director since 1990, and most recently, since being what he calls a ham and egg pediatrician was not sufficiently challenging, he decided to create an electronic subnetwork of practices within the Pediatric Research and Office Settings Network to try to expedite the process about which we can make discoveries to improve the health and healthcare for a pediatric population. So with that, I will turn it over to Mort. Thank you.
Thank you, Bob. The notion that I created anything is it's an ambitious one. Okay, so secondary, yeah, you can read that. No disclosures. So I want to review the challenges of using data from multiple different vendors in an EHR-based, practice-based research network and trace the development of what we've done to create ePROS, present a little bit of ePROS data, and discuss the lessons that we've learned. So once upon a time, there was this network, this is PROS, and about 750 practices that at least say they'll participate in research. It's probably the real number, it's more like 400 or so. Anyway, and it's a practice-based research network. It was founded in 1986 and firmly placed in an operational model from the 20th century. You know, paper, pencil, phone, fax, email. Mostly initially independent private practices. A lot of practitioner volunteerism. This is the creation of baby boomers. And the 21st century has brought some challenges and opportunities to practice-based research. So let's go with the challenges first. There's a new generation of practitioners out there. Many of you might be part of that generation. They appear less interested in practice-based research. We have not really grown over time, last 10 years, and they are actually more likely to be part-time practitioners. They have less non-clinical time available to participate in research, a non-clinical activity, and even when they're interested, competing demands for clinicians' non-clinical time have grown. There's maintenance of certification that requires some data collection activities, and there are other things. Also, as a very big change, nearly 2/3 of pediatric primary care practitioners are employees, whereas once upon a time, most pediatricians in practice were owners of their own small practices. Now they mostly work for other organizations. So even if they want to be parts of studies, they need to get approval from up the line, organizational approval. And finally, it's just narrower financial margins for those of you who are in primary care. You know, it's harder to make a living, and under those circumstances, there's less room for volunteerism, no matter whether you own your own practice or whether someone else owns your practice. But the opportunity. So more and more practices, as you've heard, are using electronic health records in day-to-day patient care. And really, EHRs contain much of the data previously collected by hand that we used to get on data collection forms for research studies. So the theory is that pediatric practitioners could help generate new knowledge about care without a whole lot of extra work from themselves or their staffs. Hooray! End of presentation, right?
No.
No. Yeah, so as my colleagues at CHOP have shown, in the single implementations of a single EHR vendor product, data can actually be readily harvested and analyzed to help produce new knowledge. And the PERC, Pediatric Research Consortium, is the poster child for this. I mean, it's fabulous. Lots of publications, great stuff, contributes to CHOP. It's a beautiful thing, right? However, pediatricians out there are using at least 100 vendor products, and they're programmed in different languages, and they have different data structures. And even when you have the same vendor product, after a few months, implementations vary. You can't find the data in the same places, even in the vendor product. It's just not that standardized. The whole way they sell these things is you can tailor it to your own needs. So people tailor it, makes it harder to find the data. Even so, opportunity was too great to pass up, especially since there was a granting opportunity. So we even tried to produce from PROS something we call ePROS. It's funded by the Maternal and Child Health Bureau. It's an ARA grant, thank goodness for the Great Recession of the first decade. So what's ePROS? It's a partnership, really. There's people at PROS, those are staff mostly in Elk Grove Village, Illinois. There are colleagues at CHOP who do a lot of the clinical informatics and the statistical analysis, and we have colleagues also at the University of Colorado, Denver, who are clinical informaticians and who really came up with the model that we've started out with. And some data extraction vendors. One's a private company called CINA, Clinical Integration Networks of America, and now there is a spin-off of the American Academy of Family Physicians, the Dartmouth Institute, which is beginning to do data extraction. So what's the data extraction about? Well, here's the theory. Let's see if I can make the arrow. Here's the arrow. That's an arrow, right? You can see that. So we actually send a server to each participating practice, which gets read-only access to the practice's electronic health record. And it extracts data elements using software that CINA developed, extracts data elements and stores them in that server, still behind the practice firewall. And then the magic of de-identification happens, and I put de-identification in quotes because it's not completely de-identified. I'll explain how. But the data are uploaded to a server in the cloud and made available to researchers. So this is what it would look like. A bunch of practices over here, your practice, her practice, and his practice. The relatively de-identified data into a single database, and the study team has secure FTP access. So that's how it's supposed to work. And what the ePROS researchers get, data on visits, children 4 to 18 years of age, because that's what we specified, from 2008 to 2011. It's a HIPAA-limited data set. For those of you who don't know what that is, it has some protected health information. Specifically, it has dates of birth, has dates of visits, it has 5-digit zip codes. So a real, someone with a lot of time on her hands and a lot of informatics probably could figure out, if they broke into the system, got past all the different safeguards, probably could figure out who people were, okay? So that's not reassuring, but it's pretty darn safe, so we're happy with it. Doesn't include names, street addresses, social security numbers, or whatnot, and this is all past the muster of a number of institutional review boards. And this is standard. You can do this without asking for patient's permission, okay? So is this going to work? That's the really big question. So we had, as part of our grant, we have these proof of concept data extraction studies looking at a couple of things we thought we could get out of the record. The first was the prevalence of obesity and related clinical findings and related diagnoses, and the second is on the prevalence of psychotropic medications being used in children, also on related clinical findings and diagnoses. And it's worth pointing out, CSI, right? Crime Scene Investigation. On some of my other slides, I actually have the music. But we call this clinical scenario investigation. Why? Because interpreting data that are not collected for research purposes and using them for research is detective work. And we have some ace detectives. So here's our status. We've enrolled 28 practices so far. We're looking for more. We've extracted data from 21 sites that represent 19 organizations. There are a couple of multi-site organizations. And the extracted data represent 15 states and 7 different EHR vendor systems. So it's national, and we're going to be a lot more national. So here's some obesity data. Okay. Right. Let's see if we can get the pointer. Here it is. So 69% of the patients, and there are about 92,000 patients in this data set, are less than the 85th percentile. And 16% are between the 85th and the 95th percentile, and 15% are over the 95th percentile. So these figures actually jive very nicely with NHANES data that were recently published in JAMA last year. It's somewhat reassuring. It looks like the system works. You have to have a height and a weight on the same date, obviously, and the patient age. And this is just another way of looking at it, but I like this because it shows practice variability. Come on, pointer. So there's some practices where only 5% of the patients are obese, and a total of less than 20% are either overweight or obese. And then there's a practice over here where 45% of the kids, 4 to 18, are overweight or obese. Lots of variability in the populations that they see. Here's a little data on psychotropic meds. Psychotropic meds is any child on a psychotropic medication between the ages of 4 and 18, any prescription at all. So you can see some practices as low as 4%, some practices as high as 21%, and the median is 10%. And another way of looking at this, practice variation, this is a feedback report. We give feedback reports to the practices as part of what they're doing. So this is one of the highest using practice. So they can see that, come on, baby. There it is. So the red dot is where they are. The X is the mean of the overall population, and the dots each represent individual practices. So these are ADHD meds, which in this case is stimulants plus Strattera, right, and guanfacine. These are people on antidepressants, people on multiple medications, in other words, more than one medication. And here are specific things. This is mood stabilizer. So here the scale is different. But in this one practice over here, not the same as that one, nearly 24% of these kids, 4.5%, 4.75% were on second generation antipsychotic medications, many of which are simply not approved for children, right? And these are the data for the 4 to 5-year-olds, a completely different scale, 3%. So, what have we learned? First lesson, okay? Many practices, especially those that are parts of large organizations, they don't like this model at all. They don't want to give anybody's server read-only access to the EHR, no matter how many business associates agreements you sign, no matter what liability things are written. And that's what happens. Our data extraction vendor has a BAA, Business Associates Agreement, with every site. They just don't want to do that, okay? So we're working on other models to supplement this. This is still nice for getting into the practices that actually house their own data and they're independent private practices. There's still a lot of them out there, but it's not going to work for everybody. So other options include using data extracts that large organizations and practices might provide, and we have some that have begun to talk to us about that, or using data extracts provided by vendors with the agreement of the practice, and we've talked to a large vendor about this. So we're very excited about that, but it is a lesson learned. Our initial model just isn't going to work for everybody, and so we'll have to work on something else. The second lesson, of course, is that although the data are standardized, they're still a function of the individual vendor system, the way in which the system has been implemented, and then the way the practitioners in that implemented system decide to use it, because they vary within practice. It's not like this is like herding proverbial cats. And finally, we've also discovered the way that data have been extracted. So once again, data analysis is detective work, clinical scenario investigation. So in conclusion, I'm going to make that plain. Extraction of EHR data from multiple implementations of multiple vendor systems is feasible, but considerable work must be done to increase the range of practice in clinical settings that our network, ePROS, can harvest data. And careful, thoughtful analysis is required to use EHR data collected for clinical care in research. Finally, have you heard this? Like someday all you'll have to do is push a button, right? And anyway, I don't think we're there yet. So thank you very much.
Thank you, Mort.
Bob knows all about the project. He'll answer any questions.
Yes, I will be happy to field your questions, Dr. Wasserman. Good luck with your travels. Our next panelist is Keith Marsolo. Dr. Marsolo has a PhD in Computer and Information Science from Ohio State University. I will find your slides for you, don't worry, by the way. He's an assistant professor in the Division of Biomedical Informatics at the Cincinnati Children's Hospital Medical Center. He currently leads the implementation efforts of their I2B2 research data warehouse, and he is heavily involved with the development of data collection and reporting systems that support multi-center quality improvement and research networks. Most recently, and the subject of his talk today, is the enhanced EHR linked registry that he's been involved in the creation of, called the ImproveCareNow network, which is a 52-center collaborative, much bigger than the ePROS collaborative, and is focused on improving the care and outcomes for children with inflammatory bowel disease. And this is what he will be presenting. Thanks.
So, yes, I think some of the conclusions that I'm going to come to are some of the same ones that Mort was just talking about, so I'll try to come up with something different as I go along. So the project I'm going to talk about is, it's a registry that we've been building, an enhanced registry that we've been building for the ImproveCareNow network as part of a 3-year grant from AHRQ. And I'll talk about the network and the grant and some of the things that we're trying to accomplish with that and some of the lessons that we've learned along the way. So ImproveCareNow is, actually the president of ImproveCareNow is at Vermont, so there must be something in the water up in Vermont to start these practice-based research networks. But the network is it's a quality improvement and research network, and it was originally founded to be a quality improvement network. Later got into the research aspects, focused on improving the delivery, the care delivery, and the outcomes of kids with inflammatory bowel disease. So looking at practice variation, eliminating that practice variation, making sure that everybody receives model care. The clinicians define the care guidelines, and then they develop the tools and the processes, to make sure that the patients receive optimal care. And this has led to improved patient outcomes, in particular remission status. So, for example, the network was started in 2007, and between 2007 and now, they've managed to increase the remission status from about 50% to close to 80%, and that's without any new drugs. It's just making sure that kids are receiving the care that they're supposed to receive. So it started in 2007 with 10 sites. When we submitted the grant, there was 27 sites, and now there's 52 sites. So I guess it's a lesson of scope creep. But we can't exactly say that we're not going to support the new centers that join the network and that kind of thing. It's a mix of public and private, urban and rural, large academic medical centers. CHOP is a participant, Cincinnati Children's, Boston Children's. And then there's also just small 2-doctor private practices. So it's really a range of systems. And it encompasses somewhere between 25 and 30% of all the pediatric gastroenterologists in the United States. The registry contains data on the patient, on disease status, and the care that's provided during each encounter. And then, so sites submit that data to the registry, and they're provided back with monthly quality reports and clinical support tools. That includes sort of run charts and control charts on their process and outcome measures, and then an automated or an access-based population management report, and then prior to the grant, a sort of just blank pre-visit planning report that they could fill in and then use that to make recommendations on the care that the child should receive during their next visit. And what I'll talk about is our efforts to automate those tools and some of our hypotheses around the impact that's going to have on the registry. So the grant itself, which we call the Enhanced Registries Grant, it was a 3-year, $12 million grant from AHRQ, and the proposal was, again, to come up with a version of the learning healthcare system using open source informatics tools to enhance an existing registry, to better enable standardization and customization of care and comparative effectiveness research. And so the aims of the grant, and I'm only going to really focus on the informatics aims. So the aims were to enhance the existing registry. So we didn't come up with the enhance, that was part of the RFA. We had to enhance the registry by linking it to the EHR. There were some quality improvement aims, so to do automated pre-visit planning, population management, and then patient engagement. Because it's AHRQ, there's a comparative effectiveness study that's actually being led out of Penn and CHOP, so some of the folks here are heavily involved in that work, and then some governance. So this is focused on IBD, but really the methods are applicable to any chronic disease of kids or adults. So this is a very busy slide, and I'm not going to go through everything, but this is the architecture of the registry. So the front end, this is based loosely on a customized version of I2B2. So we offer some cohort identification that you can do with I2B2 to find patients. There's a data entry for entering visit data. We have the ability to upload EHR data, so the data extracts that Mort talked about. And there's the patient engagement tools, which include a mobile app and a way to return a patient's registry results to them with some interpretation about how they're doing on the certain outcomes. And then there's some monthly reports, and then, like I said, the automated reports that we deliver to the network. And for this talk, I'm only going to sort of focus on the pieces of the network that are not grayed out. And so, going through the workflow, one of the things that we sort of had to do as part of this grant, and that we really wanted to do, is can we take the registry data collection form and embed that in the EHR? And that's really not hard, right? It's easy to create, thousands of flow sheets or other kind of structured data capture within the EHR. But what we really wanted to do is, can we do it in a way that we can scale it and provide it, and it's easy to install and use across the network. And I think one of the advantages that we have with this particular registry over some of the other registries that are maybe just focused on research is that the data elements that are captured for this registry are really the elements that you need to collect if you're going to give the child model care. So these are the questions that you should be asking through the course of care. This isn't the extra stuff that you're going to collect for research purposes. This is the basics. Every kid should be getting this data. Because it's pediatrics and because IBD is rare, it's not something that is it's not going to be in your electronic health records or your vendor's model system, right? So it's something that has to be sort of built through consensus. And they've worked for several years to do this. And there's about 60 questions or 50 questions that are in this form, and it's something, at least with Epic, it's something that they can pull up and collect the data. They can pull the data into a note, and then we can use it for extraction purposes. Epic, we've approached several of the major vendors that are sort of represent the vendors of the network. Epic is the majority of the centers have Epic. They've been great to work with. They elected to build this form for us, and they've distributed it to all their customers. And so that was something that's very nice. We've been trying to work with Cerner and GE. It's been a little less, we've made less progress, but we're getting there. And so the hope is that the centers can use this data to collect, and then we can use it for reporting purposes. So once we've got the data in the EHR, what we can do is you can upload it to the registry, and then that we can start to provide it back to the clinicians. And so this is something that is sort of the chronic care process. One of the ways to deliver good chronic care is to do pre-visit planning. So you plan out what you're going to do with the patient before the visit. So based on the meds, based on their history, what are you going to order any changes in medications and things like that. So rather than try to figure it out in the 15 minutes when you have with the patient, you have a plan before you go in there. And so this pre-visit planning process, and I'll show you a swim lane of how it works, sort of before automation and after automation. It's one of the ways that we can provide information back to the clinicians so that there's a benefit to them for using this registry. Sort of before the grant, all they really got out of the system was sort of monthly QI measures, which, they're important. They tell you, are you collecting all the data? Do you have any quality improvement failures and that kind of thing? But this is something that actually saves them time. And so there's an incentive for them to actually put the data in the registry so that they can get it out in terms of these reports. The other thing that we have is a population management report where, we can provide a patient level breakdown of the people in their population. We can assign risk scores for them, and then they can use the tool to drill down in the report, and then they can find out sort of who's not receiving or who's not following quality guidelines, who needs to come in for a visit, and you can just drill down into the data. So as an example swim lane, and I'm not going to go through all this, but this is sort of all the steps that would happen this is for population management, but it's similar for pre-visit planning. You essentially have to go into the chart and do some abstraction and fill out the report. And what we can do is, we don't eliminate a lot of the steps, or all the steps, but we can do a lot of that, just the chart abstraction busy work that takes 15, 20 minutes per patient. We can automate that to a large degree. So the network is pretty excited about this, and we think it's going to be a pretty big time savings. I think one of the things that we've just released these tools in the past month, so we don't have a whole lot of data yet, but I think one of the things that we're going to find is the prediction is going to be that the quality and the completeness of the data in the registry is actually going to increase, because now they're actually using this data for care purposes. It's not just something that they put in and forget, and there's more data that's on these reports. So the prediction is that the quality is really going to go up. So in terms of the progress and the challenges that we've made, in terms of the informatics, and I covered most of that, I'd say in terms of the comparative effectiveness research, which really wasn't the focus of this talk, is we have actually managed to use the observational data to replicate a randomized controlled trial and simulate a couple of others. But in terms of the challenges, and Mort sort of alluded to this, we actually, I think, have the opposite problem that Mort had. So when Mort was saying that the larger centers didn't want to have this server in their system, they just want to do data extracts, we sort of had that in spades, and even there we're sort of fighting with the data extracts that we could get. But there is a challenge to do this kind of work in the health record. It's essentially what I would call the last mile problem, is that the hospital IT groups just don't have, this is not on their priority list. And so while it's something that's important for a lot of the clinicians, it's just having them implement yet another data collection form, yet another extract, in addition to all the meaningful use and all of the ICD-10 and everything else that they've got going on. It's tough finding the oxygens to get somebody to do that. The longer term issues that we face with this is that the optimal place for the pre-visit planning and population management is actually in the medical record. So how do we build that into the medical record, and how do we get that tool available to people in the EHR? I think some of the larger academic health centers are going to do this anyway out of meaningful use or just good care guidelines. They're going to have versions of these tools. But is there a way that we can embed the decision support and the recommendation logic in the EHR itself, so that the network's sort of information can flow to the EHR? And it's just something that there is no model on how to do that today. And I think again the tension between centralized and distributed models. So with this registry, we've got a centralized model where everybody's sending the data to Cincinnati Children's. That works for a lot of centers in the network, but some of the larger centers, they don't like that. They would rather have a distributed model. And so there's a tension between sort of what approach do you take? Because in many cases, the distributed model doesn't really scale. If you're going to be in 10 of these networks, that's a lot of sort of distributed models that you have to maintain. Yet people have there's a sort of an unwillingness or a hesitation to share data. So I think it's one of those things that's going to have to shake out as we go. And it's going to be interesting to see what happens. So with that,
we'll take questions at the end. Thank you, Keith. Thank you, Keith. And we can also thank you, Keith, for getting us back towards being on time, which is great. Because I'm sure Dr. Adams does not want to stand between you and the break before the next session. So our final panelist is Dr. Bill Adams. Dr. Bill Adams is an epidemiologist, a medical informatician, and a practicing pediatrician at the Boston Medical Center. He is a professor of pediatrics at the Boston University School of Medicine, and he is the director of clinical research informatics at the Boston Medical Center, and the director of the community health informatics efforts in the Boston Health Net. You are a busy man. His research focuses on developing and evaluating information technology-based solutions for improving the quality of health and healthcare for urban populations, especially for children in these populations. His work has included implementing the child health EHR, patient-centered IT efforts, and clinical data warehousing for quality improvement. Bill also works actually with the Academy of Pediatrics to improve. If he didn't do so many things, the intro wouldn't take so long. But I would like to mention he does work with the Academy of Pediatrics to improve the quality and the implementability of the clinical guidelines that they produce, which is something that I'm on this side of, is implementing these guidelines, so I'm very grateful for those efforts. Today, Bill will be talking about his use of I2B2 for distributed health outcome monitoring and evaluation. Thank you.
They're applauding your excellent introduction. All right, thank you very much. And just stating here, I have nothing to disclose. I'm going to try to be quick. I always kick off my presentations with this slide because this is kind of my life's work. It's trying to get information out of information systems. And if I could encapsulate what I'm going to talk about today, it's like, how can we possibly enable this type of person that I call the ordinary smart person to actually get information out of information systems? So the non-programmer, possibly a researcher, possibly a quality person, to actually use the information in these information systems. The laboratory that I work in is the Boston Health Net. It's a collaboration of 8 community health centers and an academic safety net hospital in Boston. How many people are familiar with I2B2? So maybe half the room. So I2B2 is informatics for integrating biology with the bedside. It's open source software. It's used widely, including Cincinnati. It's based on the Massachusetts General Research Patient Data Repository. The nice thing about I2B2 is it's this modular design that allows cells to be interconnected. It supports a core set of functionalities like a de-identified clinical data repository, standardized linkages to standardized vocabularies, and some nice simple analytic tools, but it also allows the development of new cells relatively easily. I wouldn't say it's trivial, but it's pretty doable. And in our system in Boston, we've actually spent the last 4 years with another stimulus grant, we're getting a recurring theme here, to actually integrate all the data from our EHRs in the community health centers and BMC and the payer, the main payer in Boston for Medicaid patients, the Boston Health Net plan. We pull that all into a staging area. We have an MPI, so all the data across the network is linked. We clean it up. We try to link it as best we can to standard ontologies for I2B2, and then we push it into I2B2. And the one big thing that's really unique about I2B2 is its simple data structure. It uses the star schema. There's really just 3 tables: people, facts, and concepts, and that describe those facts. And so a fact is such a generic piece of data that we've been able to create a pretty flexible set of tools to use that data to look at a wide variety of health outcomes. And particularly what I wanted to talk about today is what we call the HOME cell, the Health Outcome Monitoring and Evaluation Cell. And the money that we got for our ERA grant was actually to assess whether health reform in Massachusetts made a difference. And this is a tool to actually assess longitudinal changes in health outcomes using electronic health data. But the design of the HOME cell is driven by this idea that you could create a tool that was easy to use, that could model essentially any exposure fact against any outcome fact, accounting for a whole bunch of temporal relationships, which in my experience has been the really hard part in informatics, is incorporating these temporal relationships, tying them to discrete time intervals like a month or a year or a time period, and then stratifying for subgroups like race, ethnicity, combinations, exposed to a certain therapy, was in a place on a particular time. Like any number of subqueries could be used to stratify your outcome, to look at this outcome in different subpopulations. And these are kind of core EPI 101 ideas being brought to bear on pretty sophisticated data systems. Just a little bit about the HOME cell. After a whole bunch of work, we really were able to come down to 3 types of constraints that could be applied to clinical data to give us that type of information that we wanted. And so the occurrence constraint just says this fact occurs in relationship to another fact by a certain number of days. So hospital readmissions rates would be an inpatient fact followed by another inpatient fact by less than 30 days. Tagging those concepts, either one or both concepts could be tied to a time interval like year or month, or none of them. It could be ever. So ever had diabetes or had a diagnosis of diabetes during a particular month. And then the idea of value constraints, so that you have a certain quantitative measure that occurs in relationship to another thing. So blood pressure following a diagnosis of hypertension would be something that you could model here with a whole bunch of different operators that could be applied to that. And then finally, especially in pediatrics, the age when things happen are really important. So you had a visit at a particular age 7 years ago, is not that easy to model in every case, and you would want to be able to do that, so you're looking at, say, cuts of a same age group over time, or certain things like that. And not spending too much time on this, I'm just going to fly through it, but the basic idea of the home cell is how do we actually build these numerators and denominators in a way that we can use within the I2B2 tool. So we start with a base query, we go to our denominator, we can specify things like had a primary care visit at a certain age during the reference interval, which in this case will be by year. We can say that they also have to have had at least one diastolic blood pressure during that reference interval to be included in the denominator. When we get to the numerator, we can start doing things like, and then was that diastolic blood pressure less than a certain number? And that represents blood pressure control. And we can do it for systolic and diastolic, and using the core I2B2 framework in terms of relationships. This is a new cell, but uses a lot of the same modeling that I2B2 does. And then this really interesting idea of stratification. So any subpopulation that can be defined in I2B2 can be applied to these sets of constraints so that you can look at outcomes within males and females and certain insurance types or certain combinations of male and female, whatever. Any query that you can model in I2B2 can be used to stratify your outcome. And then you just say, when do you want to do it? And what type of output do you want? And what's the reference interval? So does this feel like ordinary smart people could do this? It's not that hard to do. And then you just click go, and about between 3 and 30 minutes later, the data comes back after trolling through about 800 million rows and 1 million patients, and can give you these stratified data outputs with numerators and denominators and the actual proportion. And then the tool actually does some graphing here, so you can start to look at, I guess you could call them disparities, but mostly we just call them gaps or differences. So how do the outcomes in these different groups differ over time? And when you go and model 166 census tracts as a strata, individually, you can start mapping blood pressure control, say, by every census tract in Boston for the data that you have. When you look at had an asthma diagnosis within 2 years of a primary care visit over time, stratified by ethnicity, you can start to look at asthma prevalence over time in Boston for a very long time period. In literally 5 minutes is how we run these queries. And these queries were actually done by one of your own from CHOP, Elena, who just joined us, and after a month's training, she can run these queries pretty easily. This one actually looks at changes in data quality and content after implementation of an EHR form for asthma, where we built our registry back in 2005 for asthma. We put in a new form. The form lets you document daytime and nighttime symptom frequency. In the beginning, no one was doing it when we added the forms. Some people did it. Each one of these lines is a different clinic in the network, and you can start to look at network differences in actually using this tool and documenting it over time. And this was something where we had a grant, 7 years ago to do this. We lost track of it. We went back and said, well, what did that thing that we did 7 years ago actually lead to? And we can just, in 5 minutes, look at this. So then we had the question, could we take this tool and actually pop it in to 5 other I2B2s across the country and begin to do distributed queries to address, I would say in a pretty grassroots sort of way, not the elegant data integration that allows a lot of computation and stuff that's really important, but could we do it in a simple way to begin to look at a shared question within a network? So we found 4 collaborators who all had I2B2 instances already installed, and these are the collaborators and the folks. We got a very modest grant from our CTSA supplements to do this over a 1-year period. And the simple goals were to look at some cardiovascular outcomes, and particularly to look at, from a comparative effectiveness perspective, were there different outcomes in medication subclasses for different cardiovascular outcomes. Just kind of a test, a proof of concept more than a final perfect answer to the research question. And literally through bi-monthly webinars, some shared ontology development, some technical support from recombinant, and a lot more technical support actually between sites, a little bit of shared query development, and then a process whereby these queries were executed locally, and then the aggregate data was shared centrally with us. We were able to run a bunch of queries, and mostly what I'm going to show today is the results of some of our blood pressure control work on the national scale. So we had to have a really clear definition of numerators and denominators, and we had to all agree on those. We had to do a bunch of separate queries for overweight patients and older patients so that we could actually take our aggregate data and put it into a logistic model. And then we had to have a pretty clear definition of our numerator, obviously, and then the strata that we're interested in. So this is just evidence that we could actually get the home cell in all 5 sites that we were involved with. The blue line on top actually wasn't able to choose the most recent value, so they take any value in the year, so their results are kind of inflated. And one of our other sites only had 2 years of data. So what I'm going to talk to you now is about the 3 sites that actually had a good period of time. But what you can see here is for very little resources, other than the resources that have already been spent to put these systems in place, we have a cohort of 60,000 hypertensive patients that we can run some queries on. So this first one looks at obesity versus non-obesity in the 3 different sites. And what you'll see is there's a different level of blood pressure control, but these similar gaps for types of patients exist in all 3 sites. When you look at race, similarly, in all 3 sites, there's different gaps, the different absolute levels of blood pressure control, but those gaps or disparities persist. When you actually put these into a model where we take the aggregate data from each of those tables that I showed you earlier and pull them in, we can see at BMC, over time, controlling for all these other factors that we looked at, there's really been no increase in blood pressure control over this period of time. And that across all 3 sites, the racial differences persist, controlling for time and other factors that we looked at, which are obviously limited, and that obesity still continues to be a risk factor. So this isn't a new discovery, but I think the approach kind of validates that what we're doing makes sense, and that this approach of distributed aggregate queries centrally processed to look at these multivariate outcomes is interesting. The one kind of interesting thing that we found is that the racial difference within diuretics for antihypertensives is quite a bit narrower than the difference in ACE inhibitors. And while it's quite possible that the reason that certain patients end up on an ACE inhibitor needs to be considered here, this idea of different comparative effectiveness within classes by race is something that's interesting. So you can start to see how you could do some rapid kind of hypothesis generating, some digging, and then maybe go to town on actually trying to aggregate the raw data. So we, like both of the 2 previous speakers, have had some real challenges with ontology synchronization, and particularly medication. Standardizing medications has been a bear. We got mostly there. We did have an issue with data types where one place decided to categorize blood pressure by 4 different quantitative levels as a string, and everyone else did it quantitatively, so that was a bit of an issue. We're doing this with pretty limited resources, and the query performance, this is computationally pretty intense because of all these subqueries that are run and some pretty big joins, and so we have to definitely do some work on trying to optimize these queries. But my conclusions are I think this is a pretty powerful tool, especially for exploratory analyses. I would call these rapid in that what used to take me 6 months, I can do in 5 minutes now. Distributed queries are feasible and potentially informative. I'm kind of discouraged, though, that a lot of the outcomes that I thought were getting better actually don't seem to be getting better, but we've heard that in other places, too, that we've put this huge investment in our systems, but we actually have to get to the next step where things are actually improving again. And this idea of a multivariate approach to looking at some of these questions where a lot of the oversight, a lot of the privacy, a lot of the IRB issues just go away because this is not human subjects research when all you're doing is sharing aggregate data. And we think we have kind of a new approach where this data is very open, but privacy is very well protected. The focus is on measurement, not so much SQL. What I call ordinary smart people can actually ask complex questions themselves quickly. That in this framework, comparative effectiveness, health services research, and quality improvement are all supported by exactly the same common framework. The software is shareable, and I think most importantly, the logic that we use is completely transparent. Like anyone can look at how we did this. They might have questions about how the data got into the system, but they're not going to have questions about how we asked the question, which is a major problem with a whole bunch of outcome type analyses. And so I'm happy to take emails. Did I stay reasonably on time?
You did.
Okay.
All right.
And thanks for your time.
Thank you, Bill. Turn your microphone, sir. Thank you. We have about 5 minutes for questions for any of the panelists, including the invisible Mort Wasserman, who I will try to answer on behalf of. Well, while the audience is, oh, there we go.
Good afternoon. Dr. Adams, when you say you're working with limited resources, are you speaking of financial, or are you speaking of boots on the ground as far as IT people to assist in this effort?
It's just, it takes ongoing support to maintain these systems. The nice thing is a lot of institutions, I think, have committed to maintaining their I2B2. And I think also the more we make the data usable beyond the cohort identification phase, the more institutions will kind of buy into it. But that being said, our supplement's over, and we are keeping our system going. But within the network, this grant actually provided almost nothing to the collaborators across the country, and so I think it's always better to have more time and more support and more people at the distant sites, and particularly when you hit problems like medication ontology problems. It just takes work to set those up correctly, and if we had more time and resources, we could more accurately map more data and ask more sophisticated questions, and hopefully that'll improve as more people build their I2B2 instances.
Okay, one more. Go Buckeye. Unless you play at the University of Texas, then it's over. Are you working under umbrella with Ohio State Medical Center, or are you in Cincinnati somewhere working? I've been stationed up in Columbus for some time, doing some work up there too. And this is kind of new to me, your presentation.
Yeah.
So no, so Cincinnati Children's is actually affiliated with the University of Cincinnati, so it's not, we collaborate with Ohio State and with Nationwide Children's, but we are separate for now, as long as.
Hello, good presentation to you all. Keith, I had a question for you on the data registry. You mentioned your relationship with Epic and your conversations with other vendors. When you move your data dictionary, when you have new consensus or you have a new version that comes out, is that my institution's responsibility to work with Epic and my data dictionary and my local, or is that your responsibility to work with Epic, and do you have that ongoing relationship with them?
Right, so I'm going to focus on Epic because they're the only ones that have actually provided an answer to that question. So with Epic, what they ended up doing is they took on the sort of the support of that form. So you could say that ImproveCareNow owns the definition of the form, but if we would want to make changes to the form, we've already actually done this once, to add questions or remove questions, we would work with Epic, and then they would take the responsibility of updating the definition of the smart form and then distributing it to all their customers. And so for those that are Epic customers, you can actually go on their user web, and there's something called, what they call these things are clinical practice or clinical programs, and you could do a search for the inflammatory bowel disease, and there's a PDF that says this is how you install it, this is how you generate the extracts. And so they actually, I think, see this as a business, it's in their best interest to support this kind of thing. So I got in trouble the last time I mentioned this at a conference, so I'll probably get in trouble again, but they do, they do claim to offer this as a service. So if you've got your own disease registry that you want to have that form in the medical record, you could send that form to them, and they will go through the effort of tagging the elements of that form to smart data elements of what they're calling Epic, but they'll do that so that there's a place for that data to go in the Epic system, and then when it's done, they'll distribute it to all their customers. So while it's an ImproveCareNow form, it's available to anybody who's an Epic customer, whether or not they want to participate in the network. So actually, there's a group here at Penn that's doing it in adult IBD based on what we did, and so I would expect to see more of this from Epic in the future. I would hope that Cerner and GE and some of the other vendors would also sort of get on board with this kind of process, because it's really the only scalable way of getting these things into people's hands. It's enough trouble. It takes about 20 hours, between 20 and 40 hours to download, configure, move the form through all the different versions, development, test, UAT, and then build the corresponding extract. And it's enough trouble getting people to do that in certainly much cheaper than having everybody try to build this locally or based on screenshots and that kind of thing. So I would love if the vendors would all get on board with this kind of model.
Thanks for the probably got this question a lot, the ontology, the dictionary, or whatever people call that. And is I2B2 already coming with a set of the ontology that can be broadly applied to the hospitals, or just I noticed that pediatrician and others seem to be a centerpiece of the development team, maybe I'm wrong.
No. So you can comment, but so it certainly comes with enough to get you started and to get tantalized. But we found after we actually became pretty sophisticated with the system, which took about 2 years, is there is a fair amount of the data is missing, and there is no real process to maintain the ontologies themselves. So we've had to implement a process where we have an ongoing web service that talks to the bioportal and keeps track of added codes, especially around RX norm and ICD-9, which we had some issues with. We haven't really taken on Moink, but we could. But in so much as those data change centrally, or what comes with the system is missing some stuff, you're a little bit on your own. So it is an open source experience. I don't know if you had a different take on that.
So I'll just say that we opted to go with the lazy approach to ontologies, where we essentially auto-generate those out of the internal Epic data structures. So it's not necessarily mapped to SNOMED and not to RxNorm. So that's bitten us when it comes time to do these distributed query networks. So then we do go through the effort of mapping things to a standard. So there's different trade-offs. I mean, I think what Bill described is the way to do it if you need to have the SNOMED coding and that kind of thing. For some of our investigators, they know the data based on the way that it looks on the screen in Epic, and so if we don't use that mapping, they can't figure things out. So I think it depends on who your audience is, who's going to be using the tool. If it's an investigator who has no knowledge of the clinical workflow and is only going to know things by SNOMED or Moink or RxNorm, then you probably want to map to that. If it's a clinician that's practicing and they order labs based on a structure in the system, you may want to replicate that. Otherwise, nobody's going to be able to find anything. So.
If I could be more Wasserman for a moment, I would say there's value in sharing even unmapped data as well. Or maybe he says that because I tell him to. I think we have time for one or two more questions.
I was just going to say one more thing about that, because it's critical too. The nice thing about the grassroots nature of the home cell is even when you map your stuff differently, you reuse the same structure. So we can actually export a piece of XML that you pop into your home cell at another site. It lays out all the query logic, but then you can replace all the concepts with the same concepts that are in your system. So even if it has a different code, you can update the concepts. They have to be the same concepts, of course, but that logic is there, which was kind of a way to get around some of the shrine limitations where you have to have perfect synchronicity around your concepts for it to work well. I think they're both compatible and synergistic, but this kind of is a grassroots solution.
One more question?
Is there any, does anyone contrast the enhanced registry versus conventional treatment? Have you had an opportunity to do that?
I'll say on behalf of ePROS, not yet.
I don't know, not at this point.
And also, utilizing enhanced registry, does that have any meaningful use applications?
So I don't think, not yet, but I would expect it to get there. I know with like ImproveCareNow, it does count towards maintenance of certification. So there's that, but I think where it may start to get to is with accountable care and that kind of thing. And I know for the ImproveCareNow network that they've had conversations with some insurance companies where if you're part of this network and this network is shown to improve outcomes, and you're an insurance company, you could give a discount on your premiums to your clients if they opt to go to a center. So that may be one of those things from a sustainability perspective that keeps those kind of networks going.
Great. Please join me in thanking our panelists and